So in 2017, when we have started this notion that quadruplet-based regimen, CD30 monoclonal antibody, a PI, proteasome inhibitor, Bortezomib, an IMiD, lenalidomide, and dexamethasone, that quadruplet-based regimen was launched and already started in the transplant-eligible patients. But in 2017, we had experience in the transplant-eligible patient, and we knew the quadruplet was safe enough, and we thought it could be applicable to transplant-ineligible patients, although non-frail, the fit one. Like the difference between a 69 years old patient I would transplant and the 71 years old that I would not transplant is almost nothing. So it was kind of logical to try to transfer that incredible regimen to a little bit more elderly patients, but still very fit. And so Sanofi was very interested into launching that study. Now, the problem they had was that for their registrational study, they had to demonstrate the add-on value of isatuximab to a standard of care. In the particular case, in IMROS, Bortezomib Lendex. But the thing is that in many countries in the world, the standard of care Bortezomib Lendex, and in my country, the Bortezomib Lendex was not a standard of care anymore because it was replaced by the daratumumab lenalidomide dexamethasone MAIA regimen. And so we proposed, Sanofi, to do a sister study, a twin study, where we would run a phase 3 trial, but instead of asking what is the add-on value of the isatuximab to Bortezomib Lendex, we would then ask the question, if you pick MAIA, daratumumab Lendex, as a standard of care, can you improve that? Because it's a much more difficult regimen, standard of care, to improve. And if you add Bortezomib to it, are you going to make much of a difference? Which is a complete different question from the IMROS study, but a very complementary one. So it was a phase 3 study, one-to-one randomization, stratified on, as usual, centers, high risk, and age, because we recruited patients from 65 to 79, but we didn't know too much if the 75 to 79 years old that are the most elderly population in our big population our study would potentially have a lesser benefit from the treatment. So 75 was one of the stratification points. And so approximately 230 patients were recruited in either arm. And we've been moving on with the treatments, sort of an induction, and then a maintenance. The primary endpoint being at 18 months. The induction had to last until 18 months, and then the maintenance would start after that. And so for the induction, we wanted to be closer to the real life, because that's what we think academic studies are meant for. They have to develop new approaches, but stick to the real life. And in the real life, Bortezomib in elderly patients, transplant-ineligible patients, is used weekly. So in IMROS, they had to go by the Velcade, Bortezomib that is approved twice weekly. But we, in Benefit, we use it weekly. So for the first 12 months, we gave it weekly, 1, 8, 15. And from 12 to 18 months, to limit the risk of neurotoxicity, we gave it twice monthly. And so patients received Bortezomib for 18 months. Now, patients stopped dexamethasone after 12 months because we wanted also to demonstrate that the addition of dexamethasone on the long run brought nothing interesting to the patients, and it's the other way around, would brought potentially more safety issues. So the primary endpoint was MRD negativity rate at 10 to minus 5 at 18 months. So the results are, number one, that the isatuximab Lendex control arm actually did as good as well as the MAIA historical daratumumab Lendex arm, MRD around 26% at one time point 18 months. It was 30% in MAIA approximately. But most importantly, in the quadruplet arm, the ISA Bortezomib Lendex arm, the MRD negativity rate jumped to more than 50%, 53%. And that difference is really what we believe is most interesting and most intriguing and really like the groundbreaking things here, because we expected the quadruplet to do better than the triplet. We never expected the quadruplet to do twice as better than the triplet actually by just adding one drug. And so it really shows how there's just incredible synergy across in that regimen across the different drugs we'll be using, and for quite reasonable safety profile. But we might get to that. One other important point in benefit was that we looked at 10 to minus 6, and without transplant, 1/3 of the patients are 10 to minus 6 negative. This is again incredible. And one last point is that we looked at 12 months as well. So the MOD was done at 12, 18, and 24. So we also have the 12 month. And most of the patients already had the MOD negativity level at 12 months, which speaks to the fact that you don't necessarily need to give Velcade for that as many months as 18 months. Yeah, there's no free lunch at the US, I like to say. If you give 4 drugs, you will have 4 different types of side effects that might pile on, and you're going to have to deal with that. Nothing new. There's no side effect that is related to the combination. You sum up the side effect coming from each of the 4 agents. And so as soon as you can decrease the dose or stop an unnecessary drug, you immediately improve the side effects. So of course with lenalidomide, fatigue, GI, neutropenia. Of course with Bortezomib, neurotoxicity, peripheral edema in the lower limbs particularly, and GI sometimes. And of course with the CD38 monoclonal antibody, a slightly higher risk of winter bacterial infection, which are more like upper respiratory. And of course with dexamethasone, insomnia, hypoglycemia, stuff like that. But first of all, the centers are very experienced with these 4 drugs because we've been using these 4 drugs for years. So really there was no major grade 3, 4, 5 side effects, number one. Number two, again, the combination did not create any new side effect. And number 3, the relative dose intensity of either drug was more than 90%. So it means that it might have been difficult from time to time for some patients and for some centers and teams, but globally, they were able to maintain the patient on treatment for the duration of the treatment and for as per protocol. So that quadruplet, you need to learn how to use it and make it right, but it's something that it doesn't seem to be too difficult to manage. Well, the clinical impact, at least in my center, is on the next Monday. So I gave my talk at ASCO on Saturday. The next Monday, 100% of my patients have switched to quadruplet. And I think in the coming months, and I hope not in the coming years, but definitely in the coming months, the quadruplet is the new standard of care. And for now, isatuximab, Bortezomib, Lendex is the quadruplet. At IMS, in Brazil in 2024, we will hear about a 3rd phase 3 study, Cepheus, that I can tell you is confirmatory to the 2 first studies, IMROSE and BENEFIT. So yes, it's definitely the new standard of care. It's definitely the way to best treat the patients. The benefit for the patient, their family is just gigantic. We've never been that close to transplant without a transplant. So yeah, I wish any patients from at least 65 to 79 could switch to this regimen because it's just a groundbreaking change for them.